my name is Paul Collier and I'm an advanced nurse practitioner. Today I'm going to be presenting with regards to the 3 Ds, dementia, delirium and depression. We will look at dementia, including common types, the symptoms of delirium and the symptoms of depression and how these may differ in older people. The 4 learning outcomes from the session are presented in this slide, and hopefully at the end of this session you'll have an understanding of the symptoms of the 3 Ds and how people suffering from dementia, delirium and depression may present. I've not included any screening tools or diagnostic criteria in this presentation, as while the diagnosis is important for appropriate treatment and outcomes, it's essential to keep in mind that in a person-centred approach, the overriding message is that we need to focus on the person in front of us, their needs, and as well as the relative needs of the family and caregivers. You'll need a pen and paper for part of the presentation, just something to jot some notes down on as we work through some case studies. So, what is dementia? Well, the word dementia itself really relates to a group of symptoms caused by diseases which damage the brain by causing a loss of brain cells and nerve cells. The likelihood of developing dementia increases significantly with age, with 1 in 14 people over 65 having dementia. This rises to 1 in 6 for people aged over 80, and it's estimated that there are around 944,000 people living with dementia in the UK. This is expected to rise, with the number of cases in the UK hitting approximately 2 million by 2050. While the skills listed in this slide can be affected by dementia, every person's experience is unique. So again, it's important to treat people as individuals and tailor any approach to their specific needs. So while there are over 100 different types of dementia, the most common causes are the 4 types described in this slide, with 19 out of 20 people with dementia having one of these types. Alzheimer's dementia and vascular dementia account for 90% of the diagnosis, and the boundaries between the different types of dementia are not clear-cut or distinct, and people are often diagnosed with a mixed type dementia where it's felt they may have more than one cause. Common theme through the descriptions in this slide is the death of nerve cells, and the video in the slide, which we will watch now, has a great explanation of how different dementias are linked to different parts of the brain.
Dementia is a word we give to a set of symptoms affecting different aspects of thinking and brain function that get worse over time and affect the way we live our lives. Dementia is not a normal part of aging. It is the result of physical diseases that damage the brain. Everything that makes us who we are, our personalities, intelligence, emotions, our hopes and our fears are driven by this incredible organ. The brain is the most complex structure in the known universe. Intricate networks of brain cells, bundles of nerve fibers, and hundreds of miles of blood vessels all work in careful unison to keep us ticking every day. Every second of our lives, nerve cells in the brain are firing. But when these cells become damaged and their connections start to break down, a person can develop dementia. The area of the brain where this damage occurs determines the symptoms a person experiences. If nerve cells in the back of the brain are damaged, a person's vision might be affected and they may have trouble reading words or climbing stairs. If nerve cells in the side of the brain are damaged, communication and language skills can change. There are 4 main diseases that cause dementia. The symptoms of these can overlap, sometimes making them difficult to tell apart. While each disease has characteristic symptoms, these can change from person to person depending on which areas of the brain the disease is affecting. Alzheimer's disease is the most common cause of dementia. Often, one of the first areas of the brain to be affected by Alzheimer's is the hippocampus. The hippocampus controls aspects of our memory and navigation. So, forgetfulness and getting lost are usually some of the first symptoms of Alzheimer's. In Alzheimer's, nerve cells are damaged by a buildup of two proteins in the brain, amyloid and tau. These proteins are present in all of our brains, but in Alzheimer's they behave unusually and begin to clump together. Researchers are still trying to understand what triggers this, but it's likely to be a mix of age, genetics, and other factors such as poor heart health. The buildup of harmful proteins is also a key factor in other diseases behind the condition, like dementia with Lewy bodies and frontotemporal dementia. This damage spreads from one area of the brain to another as the condition progresses. So symptoms get worse over time and people begin to find more aspects of day-to-day life difficult. Dementia with Lewy bodies can affect different areas of the brain, leading to a variety of symptoms including changes in attention, sleep problems, and hallucinations. The processes involved in dementia with Lewy bodies are similar to those involved in Parkinson's disease. And people with dementia with Lewy bodies can also develop Parkinson's-like symptoms such as shaking and slowed movement. Vascular dementia can occur after someone has had a stroke or the blood vessels in their brain are in poor health. While the other diseases that cause dementia spread steadily through the brain over time, vascular dementia can progress in distinct steps after an event such as a stroke, slowing a person's ability to think, plan, and pay attention. Unfortunately, there is currently no cure for any of the diseases that cause dementia, and no treatments that can slow or stop the spread of these diseases through the brain. Researchers all over the world are looking for new ways to tackle these diseases and protect precious nerve cells. Their work has the power to offer new hope to millions of individuals and families whose lives are affected by dementia. To find out more, search Alzheimer's Research UK.
This slide further describes 4 types of dementia and what happens in the brain structures that then causes the symptoms that we as health and social care sector professionals see in the people we work with. Again, keep in mind that we need to consider the needs of the person to maintain their well-being and always working with the person and not the diagnosis. While these symptoms are typical ones we see, not everyone with a diagnosis of any particular type of dementia will display these symptoms, and the cause of the illness can differ from person to person. So, here we see a description of a person referred for a memory test. I'll read through the text and I'd like you to jot down any aspects that you feel may help or be important for a diagnosis. Mr. Johnson is an 82-year-old retired civil servant living with his elderly and frail wife. His GP referred him for a memory assessment with suspected dementia. He has been increasingly forgetful over the last 3 to 5 years, with a stepwise decline noted, and his personality has also changed somewhat. He has become very irritable and verbally aggressive, mainly towards his wife. He's lost interest in reading, his lifelong hobby, as he can no longer follow the plot of the books that he reads. He gets very angry when his wife reminds him to change his clothes, brush his teeth, or to take his medications. He has a medical history of high blood pressure, he has raised cholesterol, he has type 2 diabetes, and he had a transient ischemic attack 2 years ago. His dementia blood screen showed high cholesterol and high blood sugar, but was otherwise unremarkable. He's a lifelong heavy smoker. He scored 68 out of 100 on the Addenbrooke's cognitive examination, losing points across the board. A CT scan at the time of his TIA revealed no stroke, but moderate global cortical atrophy and extensive small vessel disease, along with some small infarcts. So, did your notes correspond with the highlighted text? This is a presentation of someone who had developed vascular dementia. Of particular note is the stepwise decline, change in the personality, his vascular risk factors, and his physical health, and the scan report. The Addenbrooke's Cognitive Examination, or ACE-3, is a standardised cognitive test designed to identify any impairment in different parts of brain functioning, and a score of below 82 can be significant. While it's a useful tool to identify cognitive problems, it is important to remember that it only forms a small part of a holistic assessment. Another description of a person referred for a memory test. Again, I'll read through and jot down any aspects that you feel may be helpful for a diagnosis. Mr. Jones is a 75-year-old retired electrician living with his wife, referred by his GP for a memory assessment due to a 2-year history of progressive decline in his memory, forgetting conversations between him and his wife and also people's names very quickly. He stopped driving 2 months ago because he couldn't concentrate in busy traffic. He now needs prompting with changing his clothes and his medications. He suffers from high blood pressure but otherwise is healthy. His dementia blood screen was unremarkable. History from Mr. Jones and his wife suggested a progressive cognitive decline with insidious onset and no past psychiatric history. There is no history of any behavioural or psychological symptoms of dementia or any memory-related risk issues. His heart rate was 68 beats per minute and regular, and he scored 73 out of 100 on the ACE-3, mainly losing points on memory and orientation in time and place. Mr. Jones appeared capacitous and he was interested in trying a memory medication. So how did you do? Did your notes correspond with the highlighted text? This case shows a presentation of Alzheimer's dementia. There's evidence of progressive decline in cognition over 2 years, along with some impairment in his activities of daily living. There are also no major vascular factors in his physical health. Here's another case presentation. Again, note down the bits you feel may be important, given what we've covered so far about different types of dementia. Mr. Williams is a 65-year-old taxi driver referred by his GP due to some disturbing visual problems, including seeing little children or dogs in the corner of his eyes over the last year or so. He has also become very sleepy during the day and had to stop working because of this. His sleep has changed and his wife says he started to act out his dreams, often appearing as if he was defending himself against attackers in his sleep. Apart from constipation recently, his medical history is unremarkable, as was his dementia blood screen. He and his wife explained his symptoms started about 18 months ago. He takes a long time to remember things and sometimes cannot remember recent events at all. He's had 2 occasions where he became very confused, but no medical cause was found in hospital. He now needs help with dressing as he can't always see what is right in front of him, and his wife has had to take over managing their bills and accounts. He's had 3 falls over the last year. He scored 78 out of 100 on the ACE-3. His memory score was only a little impaired, but he lost a lot of points on attention and visuospatial function. He also has significant rigidity in his arms and appeared quite slow in his movements. So this case represents a typical Lewy body dementia presentation. Note the 18-month history of symptoms suggesting the visual disturbances are not due to an acute problem such as an infection, and there were no issues with his blood results. The new sleep changes and acting out dreams is a common symptom of Lewy body dementia, along with the slow movements and rigidity in his limbs. Constipation is suggestive of lower motility in his bowel. He also had some episodes where he became very confused, and this fluctuation in condition is another common symptom of Lewy body dementia. This is the final case presentation, and you may be able to guess what type of dementia we're looking at here, but again, jot down any aspects that you think may help with diagnosis. Mrs. Smith is a 58-year-old primary school teacher married with 2 children and referred by the GP for gradual change in personality over the last 18 months. She has become uninterested in her family and on occasion rude and disinhibited in public. Her memory has also started to deteriorate. Her past medical history and dementia blood screen are unremarkable and she has no past psychiatric history. Her husband now feels he needs to go with her everywhere she cannot manage on her own. She has started to eat sweets only, and she gets very upset if her routine is disturbed. There is a risk of retaliation by others and vulnerability due to her disinhibited behaviour. She scored 75 out of 100 on the ACE3, and it took 3 attempts to get through the test, as she often got distracted and wanted to know if I had any children and where I bought my shirt. Her memory was not particularly impaired, but she lost a lot of points on verbal fluency and language. This is a typical presentation of a person with frontotemporal dementia. Again, there's been ongoing history of gradual change, and although memory is not greatly affected, there's reduced score on the cognitive test, particularly verbal fluency and language skills. The changes in personality of being rude and disinhibited in public are particularly pertinent, along with the changes in her food preferences of only eating sweets. So what is delirium? Delirium is often triggered by an infection or an illness, and older people and people with dementia are more prone to developing delirium, along with those with hip fractures and those with other severe illnesses. As you can see, the presentation of someone with delirium is similar to that of someone with dementia, in terms of impaired cognition and possible visual disturbances. Delirium, however, has a rapid onset and is characterised by rapid changes, such as thinking that jumps from one topic to another in a disorganised way and distracted awareness. Another major difference is significant changes in sleep patterns. Having a reverse sleep pattern, this can occur in dementia, but is more likely to occur in the moderate to severe stages of when a diagnosis is already established. When a person suffers from delirium, it's likely they will have one of 2 subtypes, namely hypoactive delirium, which can often be mistaken for depression, and hyperactive delirium, which is characterised by restlessness and agitation. Although hypoactive delirium is the more common of the 2, it's the least likely to be diagnosed correctly, as people with hyperactive delirium tend to have more disruptive presence, so they are more likely to receive attention and therefore diagnosis. Symptoms of hypoactive delirium include poor concentration, lowered awareness of surroundings and reduced mobility, while hyperactive delirium is typified by agitation, visual disturbances and lack of sleep. This video uses real-life experiences from people who have suffered delirium to show how it can affect people. So watch the video now.
When someone is ill or injured, disturbances to their brain function can cause an acute confusional state that we call delirium.
I was out with my son playing golf and did my knee in. When I woke up after the surgery, I didn't know where I was. I felt so confused and frightened. I was seeing spiders crawling on the bedsheet and strange figures and shadows in the corners of the room. Whenever the nurses tried to give me food or drink, I thought they were trying to poison me. I didn't know what was going on. It was a nightmare.
Each person's delirium is different. Symptoms can fluctuate and often come on suddenly. People can change mood or alertness very quickly. They can become agitated or aggressive, or at the other extreme, withdrawn or sleepy. They may have hallucinations or abnormal beliefs and have difficulty following conversations.
He changed completely in the hospital. Some days he would be so aggressive to the nurses they had to call security. Other days he would be so drowsy he barely spoke. Not the man I'd been married to for 40 years. We saw a doctor and one of the nurses from the liaison psychiatry team. They explained that Bill was experiencing something called a delirium, which I'd not actually heard of before. I was very happy to hear that this could be treated, because I thought I was losing him for good.
Anyone can get delirium if their illness is sufficiently severe, often those with dementia, older and frail people, as well as patients with hearing or visual impairment are more vulnerable.
The most important thing was to find and treat anything that was causing the delirium. Blood results were normal, but that didn't rule out infection or other causes of delirium. Bill had been started on strong painkillers after the operation, which were a common cause. Due to a delusion that his food and drink were poisoned, he hadn't been eating or drinking and had become dehydrated and constipated. I arranged for one of our nurses to visit the ward to support him at meal times and offer advice on some other strategies that can help.
There are often multiple causes for delirium. Anything from an infection to a change in medication or environment, even dehydration can be a cause.
Just talking to the family was very effective. We spoke to them and the ward staff about how they could comfort and manage Bill when he got agitated. We worked together to create a calm, well-lit environment with no loud noises that could startle Bill. We also arranged for his glasses and hearing aids to be brought in, and this made it easier for us to talk to Bill and explain what was going on.
Delirium is common. 10% of nursing home residents will have it, and over 20% of people in hospital. It is highly distressing and frightening to patients and carers.
I was so grateful for the support of the team. After a while I was able to go home and was told an appointment had been made for me to be followed up in a clinic. I was given a leaflet which I read, and the doctor told me that now they knew I was at risk, things could be done to try and stop it happening again.
Right now, delirium is associated with a 35 to 40% risk of death in the year after it first presents, but it doesn't have to be this high.
It's important to follow up patients after an episode. Symptoms can resolve quickly, but in some cases can persist for months. In Bill's case, the right things were done at the right time and he made a full recovery. And when he came to my clinic with his wife a few months later, though he was still able to recall his distressing experience, I almost didn't recognize him.
With early detection, delirium is preventable and treatable. The important thing is if there is any sudden onset of confusion, please think delirium. We must suspect it, spot it, and stop it.
So the above is a submitted case study of someone suffering from delirium. Can you identify the type? The individual's mother was living at home with her father in their 80s. Her mother's memory began to decline and then she had a stroke and was admitted to hospital. Whilst in hospital, she began to have hallucinations and her behaviour was out of character, beginning to swear, shout, and she was aggressive. She was diagnosed with vascular dementia and some tests were carried out to see if she had a urinary tract infection. The hospital staff wanted the lady to return home, but her behaviour was of such concern they were worried about her husband would cope. It was only when the family insisted her mother's medication was reviewed, a diagnosis of delirium was made. Several aspects of this case suggest increased risk factors for developing delirium, such as age, recent physical illness and the stroke. This lady developed agitated behaviour along with behaviours that were not usual for her. There is a suggestion of an underlying infective cause, having urinary tract infection, and although she had a diagnosis of vascular dementia, she was also diagnosed with delirium. So what is depression? Depression is a broad diagnosis in which low mood or loss of interest in pleasure of most activities are key features. Depression can affect anyone at any stage of life, and although older people may be more at risk, for example, due to more physical health illnesses, loss of mobility and confidence, and loss of social networks, this does not make depression in the older person inevitable. The symptoms of depression can differ to those typical in younger adults. For example, older people with depression may experience more physical symptoms than younger people, as well as increased anxiety or agitation. Older people with depression often deny feelings of depression or anxiety when asked directly, and are more likely to present with vague or non-specific symptoms and somatic complaints of pain, unintentional change in weight or appetite, chronic constipation, irritability, agitation, fatigue, headache, insomnia, hypersomnia, and weakness are all typical presentations of symptoms of depression in the older person. The following video gives a good example of presentations of depression in older people.
Right now, 20% of older people in the community and 40% of those in care homes will have depression. However, many go undiagnosed and many more untreated. But young or old, with the right interventions, you can reduce the risk factors that lead to depression, and it can be treated.
After I lost John, cooking for one seemed pointless. The garden got overgrown. I didn't hoover, sometimes didn't wash. I'd be in bed a lot. I couldn't sleep though, I'd just worry. I didn't read. Even the TV and radio was too much at times.
Depression can present in many ways, not just feeling low. This means older people may not realise they are depressed. They may experience loss of interest in life, tiredness, low appetite, constipation, pain or poor sleep. Older people can feel worried, become confused and forgetful. They can lose confidence or feel like a burden. In severe cases, they may think about ending their life.
I like to be active, but stopped because of arthritis. I didn't go out. Some days I didn't speak to anyone. Most of my friends have passed now, and I didn't like to bother my daughter.
Loneliness, bereavement, long-term illness, being in care and hospitalisation are risk factors for developing depression. Having a history of mental health problems like dementia can play a role, as can excessive drinking and fuel poverty. This means that depression in later life is common, but it isn't inevitable.
I had a fall and needed a hip operation. I was in hospital after that. My physio said to get out of bed every day, but I didn't. I had a lot of pain. People came round, but I felt so guilty that somehow I was a bad person for causing trouble. They worried I wouldn't cope at home and would need 24-hour care.
Depression can increase the risk of developing other illnesses and can predict the quality of outcomes for hip fracture, strokes, and even heart attacks. It can be hard to spot in older people because the physical symptoms of depression may be put down to other long-term conditions. Older people may also worry about the stigma of having depression, so may not even seek help.
I barely recognised Mum when I visited. She seemed so withdrawn. I was really worried about her. And although she was asked about pain, her breathing and other things, no one asked her how she was feeling, how she was coping with everything. I tried to visit as much as I could, but with work and my own health problems, It was so hard.
It can be difficult for carers seeing their loved ones suffering with depression. Support for them is vital, as they are at risk of depression themselves.
Once it was recognised that Mum was depressed, she got help and so did I. She was started on medication and was referred for talking therapy to help with her grief, as well as coming to terms with her physical health problems. Mum got a social worker too, who arranged support to help her adjust to coming out of hospital. She was put in touch with a lunch club and other community activities, so she's not so isolated. It also meant I didn't worry so much about her being on her own. With the support of the team, Mum went back to her own home.
Yes, you're 80, but you still feel young inside. I still get bored or lonely sometimes. The biggest help was having something to look forward to in the week. I met some new people and got out the house more. Gradually, I began to feel like me again. Oh, I can see now that I was depressed. But there are things I can do to try and prevent it happening again.
If you are concerned that someone might be suffering depression, asking 2 simple questions can be the first step to a further assessment, diagnosis and treatment. Please, don't ignore depression in older people. Reducing the risk factors can help prevent it. Depression in old age is not inevitable, and it can be treated. So ask the questions, start the conversation, see the person, not their age.
Here's another case presentation, this time around depression. Jot down any aspects you feel may be important when trying to recognise someone presenting with depression. Mr. Moore is a 77-year-old retired economist living on his own. He is never married, but he has been very active in his local community. One of his friends reported a progressive decline in Mr. Moore's memory for events and names over the last 6 to 12 months. Mr. Moore is able to wash and dress and feed himself, but he has struggled to sort out his bills and other correspondence, and they are piling up on his desk. He stopped attending the local Bible study group and stepped down as secretary of a charity organisation he has worked on as a volunteer for many years. There are no memory-related risk issues. His past medical history and dementia blood screen were unremarkable. He has no past psychiatric history, and he does not drink any alcohol. There was no evidence of Parkinsonian features. He denied feeling depressed and appeared euthymic and cheerful. He scored 78 out of 100 on the ACE3, mainly losing points on attention and verbal fluency, and on delayed recall, although his recognition of the name and address was 5 out of 5. So, with this case, although there has been some reported memory problems, Mr. Moore was managing his activity of daily living with no problems. Struggling to manage his bills and other correspondence may have been due to apathy or a lack of attention and concentration. He has become more isolative, having stopped attending the local Bible group and stepped down from a charity organisation. Although he scored below 82 on cognitive testing, his delayed recall was perfect, suggesting no issues with his short-term memory. So, coming to a conclusion, this table has a good representation of how the 3Ds differ in presentation across a range of features. And all these aspects are important to keep in mind when working with older people who may be presenting with mental health problems or unusual behaviours. Dementia, delirium and depression are distressing and debilitating conditions, and some older people may experience more than one of these conditions at the same time. It is essential to differentiate between these conditions, particularly if delirium is present, because this is an acute medical emergency that requires rapid assessment and management. Final slide is a list of references that you may find helpful to look at when looking at depression, delirium and dementia.
Thank you for watching. If you would like more information, please visit Norfolk and Suffolk caresupport.co.uk, where you'll find further training on our learning portal. The link for this website is in the description down below.